Every single day in the United States, more than 116 million adults swallow a blood pressure medication. Some of them have been taking the same pill at the same time every morning for 5 years, for 10 years, for 15 years, without a single conversation with their physician about whether the medication is still the right one at the right dose, paired with the right understanding of what it is and is not doing to the rest of their body. Most of those 116 million people know their medication by name. Most of them know roughly what it does. It lowers blood pressure. Almost none of them have ever been told the specific things I am going to tell you in this video. Not because their physicians are negligent, because a 15-minute quarterly appointment that is primarily focused on whether the number is lower than it was last visit does not have space for the conversation that the research says you need to be having about blood pressure medication, particularly after 60, when the way your body metabolizes these drugs, the way these drugs interact with the other medications most older adults take, and the way these drugs affect organ systems that are not the blood pressure reading on the cuff have become significantly more complex and significantly more consequential than they were when the prescription was first written. I am going to walk you through 5 specific things about blood pressure medication that the research clearly establishes and that most patients on these drugs have never been told. Not to alarm you, not to encourage you to stop taking medication that may be genuinely protecting you from stroke and heart attack, but to give you the precise, evidence-grounded understanding that allows you to participate meaningfully in your own care, to ask the right questions, to flag the right symptoms, to understand what your medication is and is not doing in your body, and to have an informed conversation with your prescribing physician about whether your current regimen is still the most appropriate one given your full clinical picture today, not the clinical picture from 5 years ago when the prescription was first written. My name is Dr. Leonard Marsh. I have practiced internal medicine with a subspecialty in hypertension management for 24 years. The conversations I'm about to have with you are conversations I have approximately a dozen times a week in my clinic. Conversations that patients tell me, almost universally, they wish they had been having for years. Let us begin. Before we go further, I want to hear from you. Drop your location in the comments right now. And if you are currently taking blood pressure medication, any antihypertensive, whether it is 1 pill or 3, type yes in the comments. I want to know how many people watching this are inside the conversation I am about to have, because the number always shapes what I make next. The first thing you have not been told is about the difference between controlling blood pressure and protecting the end organs that high blood pressure damages, and why those two things are not always the same. Most patients understand their blood pressure medication as a tool that lowers a number. The number goes down, the risk goes down, the medication is working. This is partially true and significantly incomplete. What blood pressure damages, the reason uncontrolled hypertension matters, is a cluster of organs that are exquisitely sensitive to sustained pressure elevation: the heart, the kidneys, the brain, the eyes, and the peripheral arteries. These organs suffer what physicians call hypertensive end organ damage, structural changes that accumulate silently over years of elevated pressure, and that manifest, when they finally become symptomatic, as heart failure, chronic kidney disease, stroke, hypertensive retinopathy, and peripheral arterial disease. Here is what most patients are not told. Different antihypertensive medications lower blood pressure equally on the cuff, but do not equally protect end organs. This was one of the most significant and most surprising findings of the ALL-HAT trial, the anti-hypertensive and lipid-lowering treatment to prevent heart attack trial, one of the largest hypertension treatment trials ever conducted, involving over 42,000 adults, and published in the Journal of the American Medical Association in 2002. The ALL-HAT trial found that while a calcium channel blocker, an ACE inhibitor, and a diuretic all produced equivalent blood pressure reductions in the study population, they did not produce equivalent rates of heart failure, stroke, kidney disease, and cardiovascular events. The diuretic, specifically chlorthalidone, was superior to the calcium channel blocker amlodipine in preventing heart failure. The calcium channel blocker was superior to the ACE inhibitor in preventing stroke. The numbers on the cuff looked similar, the outcomes were not. This research has direct clinical implications for every patient on blood pressure medication, and most patients have never heard of it. The specific question it raises for your care is this: Is my current antihypertensive regimen not just controlling my blood pressure reading, but specifically protecting the end organs most at risk given my personal clinical profile? If you have protein in your urine, a marker of kidney involvement, the research most strongly supports ACE inhibitors and angiotensin receptor blockers, which have specific kidney protective effects independent of blood pressure reduction. If you have heart failure or a history of heart attack, beta blockers and ACE inhibitors have mortality benefits that go beyond blood pressure control. If you have a history of stroke or high stroke risk, certain calcium channel blockers and thiazide diuretics have the strongest stroke-specific evidence. If you have diabetes, ACE inhibitors and ARBs have specific benefits for diabetic nephropathy. The medication that best controls your blood pressure reading may not be the medication best suited to your specific end organ risk profile. That is a conversation worth having with your physician using the specific clinical language I have just given you. The second thing you have not been told is about electrolyte effects, specifically the potassium, sodium, and magnesium consequences of the most commonly prescribed blood pressure drug categories, which accumulate silently in the body over years and produce symptoms that most patients and many physicians never connect to the medication. This is one of the most clinically underappreciated aspects of long-term antihypertensive therapy in older adults, and I want to walk through it category by category because the specifics matter. Thiazide diuretics, which include hydrochlorothiazide and the more potent chlorthalidone among the most commonly prescribed antihypertensives in the United States, lower blood pressure by promoting sodium and water excretion through the kidney. They are effective, inexpensive, and have strong cardiovascular outcome data. They also promote the excretion of potassium, magnesium, and sodium in ways that accumulate over months and years, and that produce consequences most patients on these drugs have never connected to their medication. Hypokalemia, low potassium, produces muscle weakness, muscle cramps, constipation, fatigue, and at more significant degrees of depletion, cardiac arrhythmia. Hypomagnesemia, low magnesium, produces muscle cramping, insomnia, anxiety, palpitations, and a degree of magnesium depletion that has been associated in research with elevated cardiovascular risk and insulin resistance. A study published in the Journal of the American College of Cardiology found that thiazide-induced hypokalemia was associated with significantly elevated risk of new-onset atrial fibrillation in adults on long-term thiazide therapy, a connection that the majority of patients on these medications have never heard. The specific request for your physician. If you have been on a thiazide diuretic for more than 6 months and have not had a comprehensive metabolic panel checked in the past year, ask for one now. Ask specifically for potassium and magnesium levels. If your potassium is below 3.8 milliequivalents per liter and you are on a thiazide, that is a level that the evidence supports addressing, either through dietary potassium loading, potassium supplementation, or the addition of a potassium-sparing diuretic. If your magnesium is below 0.85 millimoles per liter, supplementation with magnesium glycinate, the form with the best bioavailability and gastrointestinal tolerability, available as Pure Encapsulations Magnesium Glycinate on Amazon for approximately $25 to $35 for a 90-count supply, at 200 to 400 milligrams daily, is supported by the literature and unlikely to require a prescription change. ACE inhibitors, which include lisinopril, enalapril, ramipril, and others, work through a completely different mechanism. They block the conversion of angiotensin 1 to angiotensin 2, reducing vasoconstriction and reducing aldosterone release, which reduces sodium retention. They tend to raise potassium rather than deplete it, which produces a different set of risks in patients who are simultaneously taking potassium supplements or eating very high potassium diets, where the combination can produce hyperkalemia, elevated potassium, which at significant levels is a cardiac arrhythmia risk. ACE inhibitors also produce a dry cough in approximately 10 to 20% of patients, caused by the accumulation of bradykinin, which is a compound that ACE also normally breaks down. And this cough is the most common reason ACE inhibitors are discontinued unnecessarily. I say unnecessarily because there is an alternative class, angiotensin receptor blockers, including losartan sold as Cozar, valsartan sold as Diovan, and olmesartan sold as Benicar, that blocks angiotensin II at its receptor rather than preventing its formation, producing equivalent blood pressure reduction and kidney protection without the bradykinin accumulation that causes the cough. If you have discontinued or been considering discontinuing an ACE inhibitor because of a cough, an ARB may be the appropriate alternative. And that conversation is worth initiating specifically with your physician. The third thing you have not been told involves the specific interaction between blood pressure medications and the biological changes of aging that make the same medication dose that was appropriate at 65 potentially inappropriate at 75. This is the area of geriatric pharmacology that the research identifies as producing the most preventable harm in older adults on antihypertensive therapy, and it is almost never discussed at the point of prescription. As the body ages, several physiological changes alter how blood pressure medications behave. Kidney function declines progressively after 60 daughters. The glomerular filtration rate, which measures how efficiently the kidneys filter blood, falls by approximately 1% per year after 40 in most adults, and more rapidly in adults with hypertension, diabetes, or chronic kidney disease. Since most antihypertensive medications are cleared by the kidneys, declining kidney function means that the same dose produces higher blood levels and longer effects than it did when the prescription was first written. A dose of lisinopril or metoprolol that was appropriate when kidney function was at 75 milliliters per minute may produce excessive drug accumulation and excessive blood pressure reduction when kidney function has fallen to 45 milliliters per minute, which can happen over the course of a decade of aging without any change in the prescription. The consequence of excessive blood pressure reduction in older adults is a clinical phenomenon called hypotensive injury, which most commonly manifests as dizziness and falls, as orthostatic hypotension when standing, as fatigue and cognitive slowing, and in its most serious form, as watershed infarcts, small strokes caused by inadequate cerebral perfusion pressure rather than by the embolic or thrombotic mechanisms most people associate with stroke. A study published in JAMA Internal Medicine found that adults over 75 who were treated to systolic blood pressures below 120 millimeters of mercury, which is the target the SPRINT trial established as optimal for younger, healthier adults, had significantly higher rates of serious adverse events, including acute kidney injury, electrolyte abnormalities, and syncope compared to adults treated to a less aggressive target of 140. The blood pressure target that is cardioprotective in a 60-year-old can be dangerously low in a 78-year-old whose kidney function has declined, whose baroreceptor reflexes are slower, and whose cerebral autoregulation is less robust. Age changes the arithmetic. The specific question to raise with your prescribing physician: when was my kidney function last formally assessed with a serum creatinine and an estimated GFR? And has my antihypertensive dose been reviewed in the context of my current kidney function rather than the kidney function I had when the prescription was first written? If the answer is that it has been more than 2 years since a comprehensive medication review in the context of current organ function, that review is overdue, and requesting it specifically is an appropriate and clinically well-supported action. The fourth thing you have not been told involves a category of blood pressure management that most patients on medication have never been offered the opportunity to meaningfully explore: non-pharmacological interventions with blood pressure reduction magnitudes that rival medication efficacy in the published literature. I am not describing these as alternatives to medication. For many patients with significantly elevated blood pressure, medication is essential and life-saving and should not be discontinued or reduced without physician guidance. I am describing these as additional tools that the research supports and that can produce medication dose reduction, medication simplification, or in some cases, medication discontinuation under physician supervision in patients whose blood pressure has become well controlled. Tools that almost no physician has the appointment time to describe in adequate detail. The single most consistently powerful non-pharmacological blood pressure intervention in the research is dietary sodium reduction, specifically beyond the typical recommendation to reduce sodium, because most people have a general awareness that salt raises blood pressure without having the specific quantitative guidance that the evidence supports. A meta-analysis published in the Cochrane database of systematic reviews covering 34 randomized controlled trials found that reducing dietary sodium from a typical Western intake of approximately 3,500 milligrams per day to 1,500 to 2,000 milligrams per day reduced systolic blood pressure by an average of 5.4 millimeters of mercury in normotensive adults and 8.2 millimeters of mercury in hypertensive adults. 8 millimeters of mercury systolic. That is the reduction produced by a starting dose of most common antihypertensive medications. In patients who are already on medication and whose blood pressure is well controlled, achieving meaningful sodium reduction can create the physiological space to reduce medication doses under physician guidance, or can provide the additional blood pressure reduction needed to reach target without adding a second drug. The practical sodium reduction that the research supports requires understanding where dietary sodium actually comes from, because most people significantly overestimate the contribution of table salt, the salt shaker, and significantly underestimate the contribution of processed and restaurant food. Approximately 70 to 75% of dietary sodium in the American diet comes from processed and packaged foods, restaurant meals, and commercially prepared foods, not from salt added at the table. The 5 highest sodium-contributing food categories in the American diet, according to CDC data, are bread and rolls, cold cuts and cured meats, pizza, poultry products, and soups. Replacing commercial bread with low-sodium homemade or bakery bread, eliminating cold cuts and replacing them with whole meat proteins, and cooking soups at home rather than consuming canned versions. Canned soups regularly contain 700 to 1,100 milligrams of sodium per serving, so addresses the highest contribution categories systematically rather than requiring a general vigilance about salt that most people find unsustainable. The second non-pharmacological intervention with the strongest quantitative evidence is the DASH diet, dietary approaches to stop hypertension, which in its most consistently replicated trials reduces systolic blood pressure by 8 to 14 millimeters of mercury compared to a typical American diet control condition. The DASH diet is not a low-calorie or weight loss diet. It is specifically a pattern of foods that provide the potassium, magnesium, calcium, and dietary fiber that the research identifies as the primary dietary protective factors against hypertension. The core of the DASH diet is this: 4 to 5 servings of vegetables per day, 4 to 5 servings of fruit per day, 2 to 3 servings of low-fat dairy, 6 to 8 servings of whole grains, no more than 2 servings of lean meat per day, and limited saturated fat, added sugar, and alcohol. The blood pressure reduction from the DASH diet combined with sodium reduction is additive. The DASH sodium trial, published in the New England Journal of Medicine, found that the combination of the DASH diet and a sodium intake below 1,500 milligrams per day reduced systolic blood pressure by an average of 11 millimeters of mercury in hypertensive adults, a reduction comparable to the effect of a second antihypertensive medication. The third non-pharmacological intervention is device-guided slow breathing, which I mentioned in the context of morning blood pressure surge in a previous video, but which deserves mention here for its systolic blood pressure effects across the full day. A systematic review published in the Journal of Human Hypertension found that device-guided slow breathing, breathing paced to approximately 6 breaths per minute, which activates the baroreflex through vagal stimulation, reduced systolic blood pressure by an average of 3.5 to 7 millimeters of mercury compared to control conditions across multiple randomized trials. The Respirate device, a biofeedback breathing trainer specifically approved by the FDA as a non-drug treatment for hypertension, available on Amazon for approximately $299 to $349, guides users through a 15-minute paced breathing session that the research supporting it was conducted on. Used 4 to 5 times per week, the device produced consistent blood pressure reductions in the trials underlying its FDA indication. The fifth thing you have not been told, and I have saved this one for last because it is the one that most consistently produces the reaction I want you to have when you hear it, is about the relationship between blood pressure medication and the specific nutrients it depletes, blocks, or interferes with. This is called drug-nutrient interaction, and it is an area of pharmacology that is almost entirely absent from the conversations most patients have with their prescribing physicians. The interactions are not theoretical. They are documented in the peer-reviewed literature, they produce clinical symptoms, and they are almost universally correctable once identified. Beta blockers, which include metoprolol sold as Toprol XL, atenolol, carvedilol, and bisoprolol, deplete coenzyme Q10, also called CoQ10 or ubiquinone, through two mechanisms. Beta blockers suppress the biosynthesis of CoQ10 by inhibiting the mevalonate pathway, the same pathway through which statin medications also deplete CoQ10, and they reduce the tissue uptake of dietary CoQ10. CoQ10 is the cofactor responsible for mitochondrial ATP production in every cell in the body, and it is particularly critical in cardiac muscle, which has the highest energy demand per unit mass of any tissue. A study published in the Journal of Clinical Pharmacology found that beta blocker use was associated with significantly reduced serum CoQ10 levels compared to non-users, and that CoQ10 supplementation in beta blocker users improved exercise capacity and reduced fatigue symptoms. If you are on a beta blocker and experiencing fatigue, exercise intolerance, or reduced stamina that you have been attributing to age or to your underlying heart condition, the CoQ10 depletion produced by your medication is a candidate explanation that deserves investigation and a simple supplementation trial. Cunol Ultra Co. Q10 at 100 milligrams, available at Costco, Walmart, CVS, and Amazon for approximately $25 to $35 for a 120-count supply in the ubiquinol form that has superior bioavailability compared to standard ubiquinone CoQ10 at 1 to 2 capsules daily is the supplementation approach most consistent with the clinical research on beta blocker-induced CoQ10 depletion. ACE inhibitors and ARBs both affect zinc metabolism. ACE inhibitors in particular have been shown to reduce serum zinc by chelating it through the angiotensin-converting enzyme binding mechanism. Zinc depletion at subclinical levels produces immune dysfunction, impaired wound healing, taste alterations, and in men, testosterone suppression. A study published in the American Journal of Hypertension found that long-term ACE inhibitor use was associated with measurably reduced serum zinc compared to controls, and that zinc supplementation at 15 to 25 milligrams daily restored levels. Garden of Life. Vitamin Code Raw Zinc at 30 milligrams, available at Whole Foods, Amazon, and most health food stores for approximately $15 to $20 for a 60-count supply. Provides zinc in a whole food matrix that improves bioavailability and reduces the gastrointestinal irritation that isolated zinc compounds sometimes produce. Take it with food and not at the same time as iron supplementation, which competes for absorption. Calcium channel blockers, which include amlodipine sold as Norvasc, diltiazem, and verapamil, interact significantly with grapefruit and grapefruit juice through a mechanism that most patients on these medications have never been adequately warned about. Grapefruit contains furanocoumarins that irreversibly inhibit CYP3A4, the liver enzyme responsible for metabolizing most calcium channel blockers. When CYP3A4 is inhibited, the medication is metabolized more slowly, blood levels rise dramatically, and the blood pressure effect, and side effects including ankle swelling, flushing, and reflex tachycardia, are amplified. A single glass of grapefruit juice consumed with amlodipine can raise blood medication levels by 30 to 90% depending on the timing and the individual. This interaction applies to the entire grapefruit family, including Seville oranges used in marmalades and pomelos. If you are on a calcium channel blocker and have been consuming grapefruit or grapefruit juice without having been warned about this interaction, that single dietary change, eliminating grapefruit, may explain symptoms you have attributed to other causes and will improve the predictability of your medication's blood pressure effect. I want to tell you about a patient I will call Douglas. Douglas was 74 when he came to me for a second opinion on what his cardiologist had called resistant hypertension, blood pressure that remained above target despite 3 antihypertensive medications. He was on amlodipine 10 milligrams, lisinopril 40 milligrams, and hydrochlorothiazide 25 milligrams, a maxed out regimen on all three drugs, and still recording morning readings of 158 to 168 systolic at home. He was experiencing significant fatigue, muscle cramping in his calves at night, and ankle swelling that he had been told was a side effect of the amlodipine. His cardiologist was considering adding a fourth antihypertensive medication. When I reviewed Douglas's history in detail, in the kind of depth that a second opinion consultation allows, four things emerged that his regular appointments had not surfaced. First, he had been eating half a grapefruit every morning for 7 years as part of what he understood to be a heart-healthy breakfast. On amlodipine, that daily grapefruit was elevating his medication blood levels unpredictably, contributing to the ankle swelling and reducing the consistency of his blood pressure control. Second, his serum potassium was 3.4 milliequivalents per liter, meaningfully below 3.8, the threshold I described on a thiazide diuretic. His magnesium was 0.72 millimoles per liter, both depleted by his hydrochlorothiazide, neither having been addressed. Third, his dietary sodium was approximately 4,200 milligrams per day, well above 3,500 milligrams, driven primarily by a daily lunch of commercial deli sandwiches and canned soup that he ate because they were convenient and because nobody had quantified for him what those foods were contributing to his blood pressure. Fourth, he had never been offered a structured non-pharmacological program. He had been prescribed 3 medications over 5 years and told to reduce salt without anyone sitting with him and quantifying what that meant or building a specific dietary plan. We made changes over 3 months. He eliminated grapefruit entirely. He was supplemented with potassium and magnesium glycinate to address the thiazide-induced depletions. His lunch was restructured around whole protein and grilled chicken at home or a rotisserie chicken from the grocery store, and vegetables and low-sodium ingredients. His dietary sodium fell from 4,200 to approximately 1,900 milligrams per day within 6. Douglas's case is not about how medication failed. It is about how medication in isolation, without the full picture that surrounds it, the dietary interactions, the electrolyte consequences, the aging kidney function, the non-pharmacological tools that were never offered, produces a clinical picture that looks more complicated and more treatment-resistant than the underlying biology actually is. The medication was doing part of its job. Everything around the medication had never been addressed. Addressing it changed the outcome without adding another drug. I want to leave you with a specific set of questions to bring to your next physician appointment. Questions grounded in everything I have described today. These are not confrontational questions. They are informed, clinically appropriate questions that any physician should be able to engage with and that most will engage with positively when asked by a patient who has prepared them thoughtfully. Ask first. Beyond lowering my blood pressure reading, is my current medication regimen specifically protecting the end organs most at risk given my personal clinical history? Is it the right class of medication for my specific risk profile? Ask second, when was my potassium, magnesium, and kidney function last comprehensively checked? And has my medication dose been reviewed in the context of my current kidney function? Ask third, am I experiencing any symptoms, fatigue, muscle cramps, cognitive slowing, dizziness when standing, that might be connected to my blood pressure medication or to nutrient depletions associated with it? Ask fourth, are there structured non-pharmacological interventions, sodium reduction, the DASH diet, device-guided breathing, that have been adequately explored alongside my medication? And is there a possibility that optimizing them could allow a reduction in my medication dose? Those 4 questions, in a single appointment, open a clinical conversation that most patients on blood pressure medication have never had, and that the research suggests most of them need to have. The information to ask them is what this video was built to give you. Use it at your next appointment. I want to ask you one question before you close this. How long have you been on blood pressure medication? And has your prescribing physician ever reviewed your complete medication list for nutrient depletions or end organ protection appropriateness? Type your answer in the comments, because the range of answers in those comments tells me exactly how common the clinical gap I have described today actually is. And that gap, whatever its size, is exactly what I intend to keep building videos to close. If someone in your life takes blood pressure medication and has never had a conversation with their physician that goes beyond the number on the cuff, share this with them. Because the medication is doing one thing. The full picture of blood pressure management in adults over 60 involves a great deal more than the medication alone, and most of the people who need that full picture have been waiting in 15-minute appointments for someone to give it to them. Now you have it, pass it on.